Okay. So welcome everyone. Thank you for coming, and thank you especially to Dr. Broadhurst, our guest this afternoon. Dr. Broadhurst, he'll introduce himself, but long story short, he's a cardiologist in Aberdeen Royal Infirmary, and his area of interest is cardiac arrhythmias. I know Dr. Broadhurst through being friends with his son, and I also went on a trip to Bolivia on a pacemaker project with a charity a couple of years ago. So what we're going to do, basically, the outlay of today is Dr. Broadhurst is going to speak about an interesting case that he's been involved with. He's not currently involved with it, but he's going to speak about it. And what we can do is, if everyone watching wants to ask any questions throughout, myself, Yash, and Amir will keep an eye on the chat, and we'll just ask the questions as they come in, if that's okay with you, Dr. Broadhurst. Is that okay?
Yeah, just put your hand up if you want to interject.
Okay, no problem. Will do. Right, so I'll let you start off by introducing yourself, and then we can get into it, I guess.
Well, thanks very much, Cameron and Yasha and Emir. My name's Paul Broadhurst. I'm a cardiologist in Aberdeen Royal Infirmary, where I've been a consultant for about 23 years. I trained down in London in cardiology, but this is very much my home. And although Cameron alludes to the fact that I specialize in patients with rhythm disturbances of the heart, I also have to practice as a general cardiologist. And so I'm going to be speaking to you about heart failure today in that sort of, from that perspective. I still know quite a lot about heart failure, but not as much as a heart failure specialist, for example. And we don't currently evaluate patients. We don't evaluate patients here, for example, as to suitability for things like advanced heart failure treatments, such as cardiac transplantation or left ventricular assistant devices. Okay, there's only about 5 centers in the UK that do that sort of thing. So without any ado, I was asked to talk about heart failure in a pathology kind of interest group. I'm not a pathologist, and it is important to understand the pathology of the diseases that we treat, but to try and understand some of these things, you have to show lots of pictures of hearts and infarcts and hearts with Chagas disease and all this sort of stuff, and I can't do that. I could barely get onto the Teams app today to talk to you. So I'm not going to show you any ECGs or anything at all. I'll just talk a little bit about it. So I thought I'd start off by talking about a patient who I've known for many years. He's currently 59, and he presented in 2003 to my physician colleagues here. He had a history of diabetes, but he came in with a stroke. Okay, and from this he made a good recovery. For reasons that are not clear to me, because I don't have all of his notes, just his last 10 years of electronic patient record. He underwent an echocardiography. It's certainly a reasonable thing to do in particularly younger patients, or certainly somebody has an atrial fibrillation, or it's certainly an appropriate investigation to exclude things like mitral stenosis that we can't hear, or patent foramen ovale that can predispose to paradoxical embolus in particularly a younger patient with a stroke, because we actually close these devices to stop that as a potential cause for stroke. But he underwent an echo and he didn't find any of that. But what he did find was a dilated cardiomyopathy. Now, when we talk about dilated cardiomyopathy, there's 3 different forms of cardiomyopathy. There's dilated, hypertrophic, and restrictive cardiomyopathy, and therein probably dilated cardiomyopathy is probably the most common, and it's usually idiopathic, but there are underlying causes for it, which you can look up those. But I think he did undergo investigation for why he had this dilated cardiomyopathy. It was quite mild. The normal sort of tests that we might do to look into the causes would be certainly somebody of this age with diabetes. We would look to see if they had underlying coronary disease. We would look for things like blood pressure to make sure they didn't have, this is burnt out hypertensive heart disease. Things like this, family history. There's often genes that are associated with this when it runs in the family, iron overload, pheochromocytemia. There's endocrinological causes. So there's lots of reasons why this, but a lot of the time we don't find the cause. We do the tests and we don't find an underlying cause, and that was very much the case with this chap. Now he remained very well for until I saw him for the first time in 2010. Don't forget, his LV function was mildly impaired. You might ask, well, why did he have a stroke because of this? It may be nothing to do with the cardiomyopathy. You can get mural thrombi in left ventricles. We very occasionally do see mural thrombi in a dilated hypokinetic left ventricle, but you don't see that very often, let's put it that way. So in 2010, I saw him for the first time, and he had been referred with fatigue. Now, although he was tired, I mean, he was 49 at that stage. This was a busy guy, you know. You often phone him. If he didn't turn up to the clinic, you'd phone him up and he was on the train going to a business meeting. He was quite a dynamic, hardworking businessman with a family. And his symptoms weren't too bad. At that stage, he was on ramipril, eplerenone, ramipril 10 milligrams, eplerenone 25 milligrams once a day, carvedilol 6.25 milligrams once a day, rosuvastatin and furosemide. And he was also anticoagulated because of the prior stroke. And I think the assumption was that stroke may have been related to his dilated cardiomyopathy. His eplerenone was subsequently stopped. Now, I don't know if you know about all the treatments for heart failure. It is quite complex, and it's a moving. One of the things that I will maybe show you is the fact that they are, you know, the evidence changes for our treatments throughout medicine, particularly with heart failure, because it's a common condition. There's great interest in industry for developing new treatment, because the potential global impact on introducing a new evidence-based treatment are really considerable. Sorry, Cameron, you want to ask a question? You're muted.
There we go. There was a couple of questions in the chat it was straight off the bat. It was that we have one question saying, considering that, and this is related to COVID-19, I think the fact that you mentioned it earlier on, considering that the virus binds to ACE2 and that you would be receiving hypertensive patients, would you be at risk with the virus at the moment?
In what way? Are you more at risk of getting it, or are you more at risk of doing badly if you do get it?
I think I'll have to wait and see if the chat replies with the answer.
Well, let me answer it. Let's put it this way: if you have high blood pressure, it is a risk factor for doing badly with COVID. I mean, when you look at all the stuff, you don't have to look at the New England Journal of Medicine or the Lancet. You'd see it on the TV every bloody day, and it's a real bore. But it's very clear that the more comorbidities you have, particularly cardiovascular, diabetes, high blood pressure, underlying LV impairment, your risk of doing badly is increased. The question is, I suppose, are you more at risk of getting it, or are you just going to do badly? I suspect you're just more at risk of doing badly if you do get it. Mm-hmm. Also, these patients with these sorts of comorbidities, they tend to be older. You guys, you know, it's extremely unlikely that if you're young, without anything else wrong with it, that you'll do badly with this condition. There's some question as to whether, I think it's touched on as to whether if you're taking, because the virus binds to the angiotensin, the ACE receptor in the lungs or something. Mm-hmm. Is it bad to be taking drugs such as ACE inhibitors or angiotensin 2 antagonists? There was concerns about that initially, but from what I hear, I don't think those concerns are been substantiated. Really. Yeah. Let's put it this way: I take them. Okay, I take candesartan, and as soon as this came out, I went and got some felodipine as well, and I wasn't too sure what to do. But I think, you know, it does seem that there's no extra risk. There may be some benefit. I don't know about taking these sorts of drugs.
Perfect. And we have another question as well. Is that what's your take on reusing pacemakers and defibs in developing countries? I suppose that's quite relevant to the whole Bolivia situation, I suppose.
Right. Yeah, it's I think you only have to experience firsthand, or even have some imagination to what it must be like to live in a healthcare system in which you can't access very basic things such as medication, let alone things like pacemakers and defibrillators, which are right at the extreme end of high tech. I mean, I suppose, if there's anything we could do to improve the healthcare system in South America, it would be to eradicate the underlying cause of the majority of these patients who required pacemakers and defibrillators, which is Chagas disease, which is a parasite, parasitic infection. Predominantly affects the poor agrarian who live at a certain altitude, and if you can get them living in homes where they don't have this Vinchuca beetle, which is the vector for this parasite. I mean, 20 million people are affected by Chagas disease worldwide, mainly in South and Central America. So, that is the best thing to do if you want to more bangs for your buck. But we just involved in going to South America, and we have reused pacemakers and defibrillators when we've run out of. We haven't got enough used systems. About maybe 7 or 8 years ago, when we went there, our equipment was impounded in Santa Cruz, and we couldn't import the pacemakers and defibrillators that we needed to, and so despite high-level protests and even rioting in the streets outside the hospital, we couldn't get these things out of customs. So we had lots of patients who were pretty angry that they couldn't get pacemakers. So we re-sterilized lots of old devices and implanted them. So we have done this. We have first-hand knowledge of doing it. The duration, the battery longevity is nowhere near. We were putting defibrillators into patients who needed a pacemaker with 2 years of battery longevity, but it was that or nothing. There have been recent studies that have shown you can do these things quite safely, even in North America, where there's usually this is the home of the single use, because it maximizes, financial gain for companies and so forth. But I think there's certainly a feeling that we can do a lot more for people worldwide if we reuse pacemakers. And even in North America itself, people can't afford to get some of these treatments. Years ago, when I was a senior res, we used to reuse lots of stuff. We used to reuse catheters for ablation and all sorts of things. So you can do it.
Yeah. I think it's a lot about realizing that those problems of resource allocation and basically resource efficiency, I suppose, doesn't really just apply to the third world countries. It really it's a problem everywhere, I suppose.
Well, it's not quite a problem everywhere, because we don't have a problem like that in the NHS. You just don't see it. In fact, the most expensive treatments tend to only be available on the NHS. Some of the treatments that are routinely available for cancer therapies and so forth are incredibly expensive. So we're fortunate, and despite all the moaning that those of us who have been working in the NHS for a long time, always moaning about it and complaining and it should be better and all this. You go to these third world countries, and you realize how lucky the population are.
Yeah, absolutely. Yeah. Well, I think so we have a follow-on question. So based on that, would you say that ethics have been a barrier in terms of resource recycling, I suppose?
Well, not from ethic. You mean the ethics of reusing them?
I think that's what they mean. Yeah, I think so.
Well, there may be some. The question: is it safe to do so? Mm-hmm. Really, I don't think there's anything. I don't perceive any ethical issues. Yeah. I think there are concerns about the safety of it, mm-hmm. Whether devices are damaged or can be truly sterilized. And there may be some resistance and reluctance, certainly in the past, from device manufacturers who perceive this as a way of them making less money. I don't believe that is the case anymore. In fact, this whole of the South American the Project CAPSoc project that we're involved with, all the devices were donated by industry.
Mm-hmm.
There is more reuse. We are thinking about it now. Actually, we have started to utilize ablation catheters, and we're going to start something called intracardiac echocardiography for help with ablations, which is very expensive, echo scan that you place inside the patient's heart. It costs £18, but you can re-sterilize them and reuse them again. But the companies that CE mark the sterilization process charge you a lot of money for doing it. So it is cheaper, but it's marginally so.
Yeah.
There's always going to be some guy in the middle who's going to make money out of these processes, even re-sterilization.
Yeah, absolutely. Right. So I think there's no other questions. So I think, do you want to just continue with the story that you were telling us about?
Has anybody got any questions about the case so far?
Anything?
Anybody?
Keep an eye on the chat.
It's far more interesting to talk about Bolivia and re-sterilization of pacemakers than COVID, obviously. Anyway, so this patient, when I saw him in 2010, he was pretty good, and he was on good evidence-based treatment. There's a huge amount of evidence in the management of patients with heart failure to support what we do. And of all of these treatments that the patient is on, the only one for which there's not a great deal of evidence to justify is furosemide, actually, which is probably which is the treatment that is most likely to bring symptomatic relief. So we try and get patients on as low a dose of furosemide as possible, but as high a dose of carvedilol and ramipril as possible, because these evidence-based treatments have shown to prolong life, reduce rehospitalization. So he was okay at this point, and he was seen by the registrar in 2010, and I think he had, I don't know what he did with him, but I think he repeated the echo and showed his LV function was only mildly impaired, and he was discharged. So in 2015, he wasn't quite so good, and he got referred back to us with palpitations and breathlessness. Again, he could walk 45 minutes along the flat without too much trouble. He was still working quite long hours. His blood pressure was 110/80. There's no signs of fluid retention. When we see people in the clinic with heart failure, one of the things they're interested in is, do they have any signs of fluid retention? Because the whole issue around diuretic use is determined by that. Okay, so maybe you can give me some physical signs that might suggest the patient has got a raised intravascular volume. Anybody want to what signs are we specifically going to be looking for in these patients when we examine them?
Raised JVP.
Huh?
Raised JVP.
Raised JVP, that's very important. That's we often talk about peripheral edema. In fact, I wrote a letter this morning about a patient in a care home because they had peripheral edema and the GP assumed they had heart failure. But edema can be due to any reason. There's lots of reasons for people to get fluid retention and ankle swelling, and it's not always cardiac. However, if the patient's got pitting ankle edema and a JVP that's raised to the angle of the jaw, this patient was not tachycardic, but if they were, or they're hypertensive, all this is very much supportive of somebody whose cardiac failure is starting to decompensate. Crackles in the bases of the lungs. This patient didn't have anything, no murmurs. He did have a fourth heart sound, which you guys probably not even thought about these days, but a fourth heart sound is often is rarely a normal sound. It's quite difficult to hear it, but it's said to be a sign of forceful atrial contraction into a non-compliant left ventricle. So an ECG is very important as well, because people can decompensate because they've developed an arrhythmia. You can be very stable for a long period of time, and then you just go off, you get worse, your LV function gets worse, you become more symptomatic. Not because anything's happened to the performance of the left ventricle, but because of the efficiency of the left ventricle. The arrhythmia, the most common arrhythmia to develop is atrial fibrillation. But anyway, so we did an ECG and he was in sinus rhythm with a few ectopics. Also, importantly, his QRS complexes were narrow. Do you know why this might be relevant? Anybody like to hazard a guess as to why I've made that comment? Somebody's got heart failure, we do an ECG and their QRS complexes are narrow. Well, again, people's left ventricle can deteriorate because of the development of left bundle branch block. Do you understand this concept of right and left bundle branch block?
Mm-hmm.
So in other words, if the left ventricle is activated in a sort of incoordinated fashion because of develop of conduction system disease, and left bundle branch block is quite common. The free wall and the septum don't beat in time, don't contract in time, and you can get deterioration in LV function and increase in symptoms. So if, for example, this patient had got worse, more symptoms, and they developed left bundle branch block, and an echo showed that the ventricle got worse, one of the things that we would consider is a cardiac resynchronization pacemaker. Okay. Do you know what a pacemaker is? I'm sure
Yes.
you know what a pacemaker
Yes.
is, Cameron. You must have seen loads of them.
Amir's got a hand up.
Yes, sorry. So you mentioned obviously narrowed QRS. We always assume that that was normal, and the indication for left bundle branch block was the marrow, and the other one sort of, I can't remember, Williams and marrow. Williams. We were looking for William and marrow in an ECG.
Yes. Yeah, well, I mean, it's difficult for me I can explain what left bundle branch block does. It's difficult for me to describe it without showing you an ECG, but essentially, septal depolarization takes place in an opposite direction. So what you tend to see with left bundle branch block is the QRS complexes are broad. There may be 150 milliseconds in duration. And also there is, particularly in the left, leads to look over the left ventricle, such as V6, you don't get a little septal Q wave, okay, which reflects septal depolarization. You just get a large R wave, and you don't get a secondary S wave. So it's easier to show it to you than describe it. But essentially, you have a broad QRS, and you have it looks like an M in V6, and it might look, if you're very lucky and imaginative, look like a W in V1. Okay, so that's what left bundle branch block looks like. And if the patient's developed it, then we might think this patient may benefit from cardiac synchronization therapy, which is essentially a pacemaker with a lead usually in the top, in the atrium, and a lead in the right ventricle, and a lead in the left ventricle, but in the epicardial surface of the left ventricle, which is one of the coronary veins.
Is it more likely for them to have developed a myocardial infarction, or as you said, unsynchronized? So
no, you mean the patient with left bundle branch block?
Yeah, because we in our books we learned that a new left bundle branch block could point to a myocardial infarction.
Well, only if in certain clinical circumstances, okay, that may be the case. But just because somebody develops left bundle branch block and have no symptoms, that doesn't mean they've had an infarct. Okay, there's lots of reasons that somebody has left bundle branch block. If you see somebody if, for example, I'm on call and we have what we call a primary, somebody having an infarct, and they get sent in as new onset left bundle branch block. If this is due to a myocardial infarction, they usually have something else going on. They usually have ST elevation, quite considerable ST elevation, and lateral ST depression, and they're very sweaty and sick. So you've got to take it in context. If you just get up in the middle of the night to catheterize everybody who's had a bit of chest pain who's got left bundle branch block, you'll be getting up a lot unnecessarily and doing angiograms on patients who've got normal coronary arteries. It's clinical acumen and experience and training that allows you to determine what the cause of left bundle branch block, and could this be the signs of a myocardial infarction? Well, it can be, but it's not as straightforward as that. So this guy, we repeated his echocardiogram, and it showed actually that in the 4 years since his previous one, his LV had got bigger. His left ventricle was more dilated, and his ejection fraction. Do you understand what we mean by the ejection fraction? It's a rather crude term, but is quite useful still, of the amount of blood that's ejected with each cardiac cycle, each heartbeat. So normally when a heart contracts, it pushes out about 50% plus of blood that's in it at end diastole. But this guy, his ejection fraction was about 32%. So it's quite significantly impaired. It's not a one of the reasons for looking at the ejection fraction, particularly in somebody whose function is deteriorating, is sometimes to think, is there anything else we can do to improve this man's longevity? Because the worse the heart function, the more chance the patient's got of dying. And one of the things that we do, and in 2015, we wondered with him, is would he benefit from more aggressive medical treatment? Or would he benefit from he wouldn't benefit from a cardiac resynchronization pacemaker, but would he benefit from a implantable defibrillator? Okay, because some of these patients will go on to die from ventricular fibrillation, just drop down dead. Okay, and certainly the data up to that point in time suggested patients may benefit if their LV function, their ejection fraction is less than 30%. And don't forget, this guy's relatively young, he's 54. He's got nothing else on the horizon. His cardiac function has deteriorated, but he's not got severe symptomatic heart failure. So for example, if your ejection fraction is 26% and you're stuck in bed with highly symptomatic heart failure, we wouldn't give you a defibrillator because you're much more likely to die of pump failure. But if you're functioning very well, then maybe the highest you're particularly risk of, if you're going to die of ventricular fibrillation, which is something we can treat with a defibrillator. So we did fiddle around with his tablets a little bit, but we discussed with him whether he wanted an ICD, and we were thinking about offering a subcutaneous ICD, okay, which is like a defibrillator underneath his skin, outside of his rib cage, okay, which has got some advantages, particularly for a primary prevention device. In other words, a device implanted in somebody who's yet to have an arrhythmia, ventricular arrhythmia, over conventional ICDs, which are implanted like a pacemaker is. So we discussed this with him, and initially he was a bit skeptical, and then he came around to the idea. About 4 months later, there was a study published called the Danish study, which they looked at about 1,000 people in Denmark and followed them for 5.5 years of patients with non-ischemic cardiomyopathy. So in other words, the commonest cause for patients to have poor left ventricular function is coronary artery disease, myocardial infarction. But this guy has got a non-ischemic cardiomyopathy. And what they showed, this particular study, was that there was no overall benefit. Okay, you did save a few people's lives from, dropping dead from ventricular fibrillation, but overall, just as many people died from heart failure in the group that got the ICD as that didn't. So that, plus the fact there was also some new treatment. Have you ever heard of Entresto? Any of you heard of Entresto? It's sacubitril valsartan. So it's another big study that was published around about maybe a year or so before that. Again, it showed very good results. Patients who got heart failure, despite good treatments such as ramipril and beta blockers and eplerenone, if you give them Entresto, which is a drug which contains valsartan, and the neprilysin inhibitor, sacubitril, they actually did better. They lived longer and had less heart failure hospitalization than if they were taking an ACE inhibitor. And it was highly significant. So I said to this guy, look, I'm not sure you've got much to benefit from having an ICD, okay? But we could improve your prognosis probably more reliably if we gave you this new drug, Entresto. So we started him on that instead. And he did really very well for quite a few years. He had some problems with erectile dysfunction. And when he was seen in the clinic in December, he was starting to get a bit more breathless, and the erectile dysfunction was a big problem for him. And beta blockers and diuretics are associated with erectile dysfunction. This was occurring despite using sildenafil. He'd also been to see the urology nurse who, evaluated any other treatments that might be relevant to him, but this is a big problem for this guy. So he had his beta blocker stopped, and his condition improved for about 3 months, and then it deteriorated. March of this year, he was admitted into the surgical ward with abnormal liver function test, which I think in hindsight was congestion. They fiddle around with his tablets a little bit, but he had several more admissions with heart failure, and it's becoming very clear he started to lose weight, cardiac cachexia, which is often a sign of increasingly severe heart failure. This is, don't forget, he's on good medical treatment at this point. With Entresto, he does get some beta blocker reintroduced. His JVP is not elevated, but he's starting to become hypotensive. And he was admitted after 3 admissions to eventually got admitted into the cardiology ward about a month ago. Can you think of any other treatments that we might wish to consider? So his QRS complex is still narrow. He's on Entresto and a beta blocker and diuretics and Flarin. Any other treatments that you might consider in a 59-year-old man?
I mean,
Well,
I suppose, was he showing any other systemic signs? So was it having an effect on, you said he was examined by the urology nurse and stuff, other than his erectile dysfunction? Was there any other major side effects that he was experiencing?
No, don't forget that was in 2017. Okay. Mm-hmm. When he's now admitted with heart failure, once to the surgeons, once to the physicians, and most recently under the care of cardiology. And he was hypotensive. Okay, so he has an echo. If somebody's hypotensive, you should do an echocardiogram to make sure that you don't have a pericardial effusion causing tamponade. And he didn't have that, but he did have quite a lot of mitral regurgitation, which is you tend to see in these patients as the ventricle gets bigger, the mitral ring gets more stretched and the mitral leaflets cannot oppose. So you often get what we call functional mitral regurgitation. So the things you have to think about is this guy a candidate for a new heart, cardiac transplantation? And he's a Jehovah's Witness. Do you understand what the implications of that are?
Yeah, so they don't accept any organ or blood transfusions.
Well, that's not true. Somewhat surprisingly, they will not accept any blood, but they will accept a new unit. They'll accept a new heart, which seems a bit odd to me because you can't flush out, or it makes the surgery often very difficult. I mean, we have had patients, I've certainly done ablations in relatively bloodless procedures, but there are techniques, salvaging techniques for cardiac surgery. So patients with Jehovah's do go through cardiac surgery. But I think this, in a 59-year-old man with a history of stroke and diabetes, and will take a heart, but he won't take any blood, that proved to be too much.
Guys, I think we've lost the connection there.
Yeah, I think we have. I don't know what's happened. We've lost connection with. Oh no!
Sorry.
Oh, no problem.
Yeah, you see me? I don't know what happened there. So anyway, he gets a second opinion, and he can't have a transplant in Newcastle either. And he realizes his condition deteriorates despite inotropic support. So his heart failure is managed with dopamine to try and keep his blood pressure up, diuresis. And when he realizes there's no option for him, we discharge him to go home, which is where he wants to be, some digoxin. I don't know what's happened to him since, but obviously his prognosis is very poor. So this is the sort of, it's not, each what we call patient journey is very different. But what this case I think does illustrate is the complexity of the management with patients with heart failure, the things you have to consider when you're looking after them. And also you have to be prepared to change your approach, because, you know, you're looking after this man, he's been kicking around the hospital for 17 years. And in that time, the way we approach these, you know, CRT therapy really wasn't widely available in 2003. It's never been relevant to him, but it could have been. And the whole approach from not using primary prevention ICDs, using sacubitril valsartan, all these sorts of things are relevant. So you have to, it's one of the arguments for not discharging certain sorts of patients, okay? You come under pressure a lot to discharge patients from hospital back to their GP, and we do that. But one of the arguments for not doing it is you're in a bit of a better position, so that if better treatments come along, you can offer them to patients.
I think it's interesting that you pointed out the complexities of you know, patients with heart failure, and that we have a separate course called narrative medicine. So we each get assigned a patient, and we have to take their history, and we have to basically write an essay discussing their past medical history, and then discussing their management and things, and looking at the complexities of their case, and how the use of multidisciplinary teams allow for almost compensation for complexities in cases. So would you say that in your experience of this patient, I know he wasn't your patient towards the end and he isn't at the moment, but the use of MDTs, would you say that that was a very important thing for this particular man, would you say?
Look, I'm old, you know, and I'm not the big fan of routine use of MDTs. We sometimes call MDTs muddled departmental thinking, you know, and I think if you don't know what to do, then, you know, you should ask other people. And we do that all the time. We do have MDTs, you know, there's no question we do it when we discuss difficult revascularization strategies, whether angioplasty or whether patients undergo cardiac surgery or not at all. The management sometimes of endocarditis, but you know, I think it's being used a little bit too much at the moment. It tends to sometimes slow things down. I think if you're doing something like cardiac transplantation, you know, I can certainly see that it has a role to play there. But I think, you know, if you're trained to be a cardiologist, you should be able to manage most patients. You also should you should know what you don't know, and that you could say that about all walks of life, and not have and have the sufficient humility to ask for help when you need it. And I do it all the time, but I don't discuss every single case in an MDT. Something like this is very straightforward. We have huge amounts of evidence to guide our decision making. You know, if we've made an accurate diagnosis, you know, the management of patients with use of these drugs that we've used, it's easily justified, and we just get on with it. It does become a bit more difficult, you know, from time to time, but you can't make every decision with an MDT. You'll get, you know, medicine will just disappear if you try and do it that way. But it has its role, okay, but I don't do it for everything.
Yeah. Well, I think it's interesting as well. So you mentioned getting the accurate diagnosis. So in your experience of cases like this guy, it became very clear that the ECG was quite important and stuff in you know, progressing and allowing you to make more informed decisions. What would you say would be the most common ways of diagnosing heart failure, so to say?
Well, it's easy in hospital. It's quite easy. I mean, you know, a lot of the stuff is filtered out by other people. So when a patient gets referred to us with breathlessness, there's a real chance they could have heart failure because somebody else somewhere has taken a history and their breathlessness is not due to COPD or obesity or you might think that actually, but it's not always the case. But if you're in primary care, it's much more difficult. If you're a generalist, particularly if you're a general practitioner, you have to look after everything that comes in through the door. You can't say, oh well, you know, your left ankle's a bit sore, isn't it? But you're going to see a GP about that. The buck stops with you as a general practitioner. So, and GPs obviously don't have the experience and training to manage these sorts of highly complex patients that we do, but we don't have to do anything else. Okay, so it's quite easy for us. In an attempt to minimize the strain, if you offer GPs the kind of investigational facilities that we have within reason, such as echocardiography, they could easily overwhelm the even secondary care's resources for this. So if somebody's a bit breathless, I'll get an echo. You know, this is what happens in hospitals a lot of the time. But so there is this thing about use of BNP, okay, brain natriuretic peptide, and the GPs certainly around here do use that. This particular patient, the GP measured the BNP, and if it's less than 400, it's not elevated. Okay, when he came in March, when he was ill in March, starting to get symptomatic, his BNP was 20,000, and we don't have access. We don't use it. We use our clinical acumen, and you know we just know when somebody's breathlessness is likely to be due to deteriorating LV function. We can get an echocardiogram as well quite easily. The BNP is very useful. So if you're breathless and your BNP is not raised, then the GP will think again about requesting an echocardiogram. You know, and think about, you know, is it more likely to be the lungs? But I suspect we will be moving towards more open access, you know, investigations. GPs can request echoes directly, but they also know that if they just request echoes for everyone who's breathless, the system will be swamped. And the current waiting time, the waiting time in the COVID era for an echo is about a year here, because they're not doing any echoes because we're not allowed to bring elective cases into the hospital at the moment in case they get COVID. So yes, we also have, don't forget, patients with breathlessness, and the reason it's important to examine patients is also to make sure there's no murmur. You know, people can be breathless because of aortic stenosis or mitral regurgitation. Valvular heart disease is very important as a cause of heart failure, but obviously that's a different, not due to heart muscle disease, it's due to valvular disease.
So just a quick question on, I guess, prevalence of these kinds of diseases. Heart failure, or like you said, valvular disease. Are there any particular reasons, demographically, I suppose, contrasting? And you said you trained in London, and you now work in Scotland, obviously. Any demographic things that you would say, I suppose, predispose the amount of cases that come to you? So in terms of heart failure and valvular disease, etc.
It's totally dependent on where you live and work. So, for example, if you can see someone with heart failure in South America and they're 32 years old, the chances are they've got Chagas disease, Chagasic cardiomyopathy. If somebody's breathless in the Indian subcontinent at a young age, there's a high chance it's rheumatic valve disease. Okay, we see very little rheumatic valve disease in the UK now, certainly outside of London, where there's not a high instance of immigration. So in the northeast Scotland, the sorts of causes of heart failure are ischemic heart disease, the consequences of myocardial infarction. Although sometimes you just have sort of LV dysfunction deteriorates gradually because the patient's got diffuse coronary disease. But one of the reasons that we get out of bed in the middle of the night to unblock a coronary artery is to limit the size of the infarct so the patient doesn't end up with heart failure. Okay, so ischemic heart disease, hypertension can cause heart failure, and it's not always obviously recognized, but one of the reasons for managing patients' blood pressure is to prevent this. And then this is out with valve disease. Then dilated cardiomyopathy is third commonest cause. If you look at the elderly population, then valvular disease becomes much more likely. if you have somebody who's breathless, who's 85, and they've got a systolic murmur, the chances they've got severe aortic stenosis. And with the successful introduction of TAVI, do you know what I mean by TAVI? Transcutaneous aortic valve implantation. It opens up a treatment option for many people who'd be considered too frail for routine valve surgery. And then you just find lots of patients then who come forward or are found to have aortic valve stenosis, who get referred to you for TAVI, or I refer to one of my colleagues to do that.
So when, oh, sorry, Yash, you've got a question.
Dr. Broadhurst, I was just wondering, as a specialist that's been working in this field for a very long period of time, what your thoughts are on cardiac regeneration. Because we read articles every now and then about whether it's using stem cells or transdifferentiating adipose tissue or something like that. And I was wondering if you see that as a plausible treatment for the future or not.
Well, it's possibly a treatment for the future, but it's not a treatment for now. I think it'd be fair to say. It has been around. There's been trials of this, but I don't know enough about it. But we would do if it was a real treatment option, and I don't think it is at the moment. But it might change. It could easily change.
Thank you.
Amir, you've got a question?
Yes, sorry. I just wanted to ask you about the sort of commissioning and the recommendations of NICE of these new medications that you mentioned. You gave an example of in Entresto.
Yeah.
I was just wondering how you sort of so when these new drugs come out, does an external body approve them and then you have to use them, or do you rely on the data yourself? And how do you then get the commissioning for these medications to give to patients?
Well, it depends on how common it is, really. I mean, there is an example of a drug with very strong data that we do use a bit. I don't know where it is with NICE. It's the drug. Have you heard of dapagliflozin? It's a diabetic drug. I can't remember its mode of action. Again, it was tried in a very large study, which was published in the New England Journal of Medicine about 6 to 12 months ago. It showed highly significant improvements in outcomes in patients who were well treated. It wasn't a complicated drug, and it's one that's already available and used by diabetologists. And we do use it a little bit from time to time, but we haven't gone out into the community and said to the GPs, all your patients with class 2 or 3 heart failure who are already on these treatments should start on this drug. Because of these sorts of issues that you mentioned, they're often financial considerations that need to be taken into consideration. The commissioners and providers of healthcare in Scotland are the same. Okay, so it's not as it quite is in the rest in England, but there's often, I'm afraid, a degree of reticence. It's often a little bit more difficult to introduce new treatments that are going to cost money than it is to introduce treatments that are not. And people want to be more confident that this is the right way to spend their money. The providers of the treatment, the payers of the treatment, and this sometimes leads to some what we find frustratingly slow means of introducing. I was speaking to one of my colleagues who's the local heart failure specialist, and about this issue around dapagliflozin. And our local transplant center is in Glasgow, which is about 150 miles away. And he'd been speaking to them there as to whether they're using it as a matter of routine in the heart failure center there, and they're not. But they do prescribe it a bit like we do here, in small numbers. But we're not going out evangelically and saying, all you patients with heart failure and who are with these X symptoms and on Entresto, you need to be taken to the
Mm-hmm. Thank you very much. I think we have another question in the chat. So Maureen is asking, does the risk for erectile dysfunction from diuretic use increase with increasing age?
Oh, I don't know. I don't know. I don't know that. Most things do. Most things get worse as you get older, I'm afraid, and I'm testimony to that. I think these drugs are. This problem can develop in men of a certain age, irrespective of the medication. There's not always an underlying treatment, and in fact, there's quite a strong correlation between erectile dysfunction and cardiovascular risk.
Mm-hmm.
The question, I suppose, the interesting thing about this case is what caused this man to deteriorate? Was it just the natural history of his condition, or was it withdrawal of the beta blocker? That's of slight concern, because beta blockers are very powerful drugs that are reducing risk in patients with heart failure, and we stopped it for good reason. Well, the registrar stopped it for good reason, but could that be the reason that the guy deteriorated and spiraled out of control? We don't know.
So in terms of, do you mean like the beta blocker basically kept him at a certain level that stopped him from deteriorating, and as soon as they took him off of it?
Well, didn't happen straight away. When I was at your stage, or even a little bit older, beta blockers are considered complete no-no, and then there was a chap called Vaxstein in the mid-1970s of Swedish cardiology, somewhat very controversially started giving beta blockers to patients with heart failure, and the reasons. Well, beta blockers are negatively inotropic, at least acutely, and this is a condition which, there's a problem with left ventricular systolic function. So you cause a reduction in left ventricular systolic function if you give somebody a beta blocker. But at the same time, patients with heart failure tend to have high levels of circulating catecholamines, which may be cardiotoxic. So Vaxstein came up with an idea that maybe we could protect the heart by giving beta blockers, and wrote a paper and published it in the Lancet to suggest this. And in the mid-1980s, in fact, I was involved in the development of carvedilol as a research registrar, and we used to inject it into patients with heart failure, and showed that there were no adverse sequelae from even injecting it. And then we showed that it was a drug that was well tolerated if you used it in low doses to begin with, and increased the dose very gradually. And now it's been shown in very large studies that it's beneficial, not just in terms of quality of life, but quantity of life as well.
Mm-hmm. Yes, you have a question.
Yeah, I just have two questions. My first question is, in this particular case for this patient who had erectile dysfunction, is it because of the cardiovascular risk that he's not given drugs such as like Viagra? And the second question,
he did get that. He did get Viagra. It worked very well with him. It doesn't always work.
Okay, so it doesn't matter on the cardiovascular risk or anything. Viagra.
No. I mean, there are drugs that they're contraindicated with Viagra, particularly nitrates, because it'll push your blood pressure down and it won't come up.
Yeah, thank you so much. And my second question is, you've kindly mentioned how the way you treat patients have evolved over the years. I was wondering if there is any regulations or rules into this, or is it just based on the choice of consultant that you start treating patients with the new medications or the new therapy that arrives? I was wondering.
No, there's plenty of evidence based. There's plenty of evidence to support what we do, and if we're half good cardiologists managing these patients, we have to keep up to date with it. And what the guidelines suggest that we should be doing, there's often a lag between what the evidence suggests we should be doing based upon very large high quality studies which have been peer reviewed. That might make us, particularly in patients who we're very concerned about, go for some treatment that is usually in addition to what is recommended by the guidelines. So so that's what we do. We're not cavalier. It's not the Wild West here or the Wild North. we're very lucky in cardiology. There's a huge amount of data to support our practice, particularly in heart failure, more than anything else. Every single one of these drugs, except the one that makes this guy feel the best, which is a diuretic, everything else has been shown to improve his quality and quantity of life. Okay, that's, you can't say that for all specialties, and you can't say it for other areas within cardiology, but there's still a huge amount of data to support what we're doing in cardiology, because cardiovascular disease is very common.
Mm-hmm.
Even in my area of so-called expertise in electrophysiology, there's large trials showing that most of the interventions that we do are highly effective, better than the alternatives.
Mm-hmm.
If there was two different treatments, one of them new and one of them relatively traditional, and you, for example, were sure that the new one would work, but a different cardiologist would be more traditional and would base his therapy on the patients based on the traditional drug, how do you resolve this conflict? Is it just a matter of choice, or do you have to talk?
Well, no, it's the way studies tend to be done, and it's just not necessarily the best way of working out what the best treatments are for patients, is they tend to be add-on treatments. It's very rare that you see a study that is published in which a traditional treatment is stopped. If the traditional treatment has been shown to be beneficial, that is the standard of care. And the question is the new drug X, is that better than the standard of care? So what we tend to do is, if a new drug comes along, we add it. This is why patients are on so many drugs. I don't know whether, Entresto and beta blockers. Well, let's you need to keep taking beta blockers, for example. This is an example. It's don't quote me. If you're prescribed dapagliflozin, we just don't know that. The studies aren't conducted that way. They're always add-on. ICDs have been shown to benefit patients, particularly if they've got ischemic cardiomyopathy, they've got depressed left ventricular function, who've got less than class 4 heart failure. If the patients with heart failure are well treated pharmacologically, then they can expect some benefit from an ICD. So it's always add-on. It's not difficult to do. The question is, do you want to take the risk? Are you what we call an early adopter of new treatments, or are you the last guy to get to the bar? I'm quite an early adopter in terms of introducing new treatments, drugs, in terms of ablations. It just reflects one's personality, and people are more cautious, if you like. Yep. If I have a hunch that a specific treatment sounds like it's good, then if I can, I will evaluate the data and recommend it to my patients. And it's usually born out. I've not done anything I've regretted, and it's not ended up in some guidelines.
Thank you so much, Dr. Broadhurst. Appreciate it.
Yeah, thank you. I think so. That's us just come up to an hour now. I think I'll call for any last questions into the chat, based on the case or any questions that you had beforehand that you've left until now. But just wanted to say thank you very much to Dr. Broadhurst for joining us, giving us your time. Like you said, other parts of the hospital can be very busy. You might not be busy yourself at the moment, but we still appreciate your time very much. I know it definitely helps myself and other students who have already done the cardiovascular system. So it's always good to hear it from a different perspective and not necessarily in a lecture form. So thank you very much for your time. It means a lot to us. So for everyone, the video it's been recorded, so it'll be uploaded onto the website sooner rather than later, I believe. So I don't think we have any questions. Keep you waiting too long for no reason. So I think on that note, I think we'll finish up there. If anyone, Amir and Yash, do you have anything else to add or ask?
Thank you so much. Thank you. This was
a pleasure. Okay.
Thank you so much, Dr. Broadhurst. Thank you.
That's fine. Okay. Right.
Yeah.
Bye-bye.
Thank you
See you,
so much.
CAPSoc.
All right.
Bye.
Yeah. Take care, Dr. Broadhurst. Thank you.
Bye-bye.
Bye-bye. Okay, Amir, if you want to end the recording.
Yes.